Now, so among the causes, those that we should discuss in the course of infectious diseases, you have the bacterial, and the bacterial are the Haemophilus influenza, the Listeria. By the way, the recent outbreak of Listeria, it was in Zimbabwe, South Africa, and Namibia last summer. And it was the reason of this outbreak. It was the contaminated ham and basically the meat, packaged meat from the shop. So people were getting ill due to due to the meat, which was not properly sealed, contaminated with listeria. Listeriosis could also appear in people who do farming, especially the ones who make cheese, the fermented cheese and cheese with the mold. That's the most common cause. Now, meningococcus, that is the one that we're going to discuss over here. And the meningococcal meningitis is really widely distributed. So when you answer in the class, when you answer to the question of epidemiology, and when you say India, Africa, and some Asian countries, that's, that's crap. So what you should be telling is the specific regions. Now, meningococcal meningitis is epidemiologically significant in the European countries, of course, and the North European countries because of the cold climate, as well as for well, there are many theories why it is common there, but it is very common in sub-Saharan Africa. So those areas they have meningococcal vaccine in their yearly calendar. So you even the healthcare system is even providing the vaccine over there. Mumps, pneumococcus, group A, streptococcus, group B, streptococcus, beta hemolytic group A, and group B, streptococcus. These are the ones that are actually, we consider them to be as a normal microflora or the opportunistic microflora. However, they also may cause the meningococcal, the meningitis, bacterial meningitis. Now, among the viruses, we have arboviral, which is mosquito-borne, and these viruses are very common in Asian countries. Now you have influenza, which may cause meningitis, cross-encephalitis, vaccinal, and enteroviral, the ones that we discussed, the Coxsackie. You remember we were talking that it may cause the meningitis or encephalitis or both meningoencephalitis. So again, this depends on, it really truly depends on the immune response of the host, because sometimes the development of viral meningitis is usually because the host may not be able to withstand the viral load and the accumulation of virus in the body in general. The symptoms. So there's sometimes, you may have, this is something that is really important for you to distinguish, because you may have the symptoms which are common for both viral and bacterial. And this coming week, we're going to discuss meningitis, which is bacterial meningitis. I do want you to be able to distinguish, to differentiate between viral and bacterial, but then I also want you to make sure that you focus mainly on the bacterial, because that is your topic for this. So when you tell me the clinical manifestation, when we discuss the symptoms, there are common symptoms, so don't just focus on those, because these are the common ones. They're obvious, they should be there, and that is the fever, chill, mental status. Mental status, that's disorientation, anxiety, or the loss of consciousness. So that's basically the mental status. Nausea and vomiting, sensitivity to light, photophobia. Now, photophobia may be It may be even in other diseases, not necessarily in meningitis. Severe headache or the cephalgia, and stiffness. Neck stiffness, right? Again, this is not a very specific symptom, so that's why you shouldn't really be focusing on that. So here we have viral meningitis, and you have the clinical manifestation. Basically, it's the syndrome or symptom complex, which has the fever again, and then it has the meningeal symptoms, which is the stiff neck, the Brudzinski, Kerning sign. But again, what is uncommon for the viral meningitis, and well, it's not really uncommon. What is impossible for the viral meningitis is the pleocytosis, that the macrophages in the CSF with the bacterial cultures. Well, basically, it says here bacteriologically sterile cultures, which means that if you do the culture of the CSF, they're going to be negative. You won't be able to find any bacterial cultures over there. Basically, that's what we call aseptic meningitis, because there's no evidence of bacterial or fungal meningitis. Now, fungal meningitis, well, this is just for your reference. It's really required for this coming week class or the module. The fungal meningitis, it's either the patient is immunocompromised because of HIV/AIDS, or the patient has been overtaking antibiotics, and usually such fungi as mucor or such fungi as is, well, basically these are the mold fungi, the black mold fungi. These are the ones that are present in the host, in the human being, if it is an immunocompromised host, especially after the chemotherapy, especially after the brain surgery, the organ transplant, because that's when we use a lot of corticosteroids to suppress the immune system. So then you have the bacterial meningitis, which is mainly common among such species as you can see here, Neisseria meningitis and Haemophilus influenza. And the interesting thing is that even we have the vaccination for these two things. However, people are not really excited about going for the vaccine. Now, all right. So this is a little table that I want you to kind of focus on. You can see here the symptoms. Hold on a second. I'm trying to. Is there any way I can actually do? Yeah. All right. So all right. So on the left, you have the symptoms over here. I will be very kind enough to send you this presentation so that you can keep it. And I would really appreciate if you would even print some of these slides over here. It's not going to cost you a lot of money. But then if you can print this, and then if you can glue it into your notes, this will be really helpful, especially for the next year, because it doesn't matter which teacher you're going to get for your cycles, but this information that's here, it's something that you will be required to know for the CROC2 to differentiate between tuberculous meningitis, meningococcal meningitis, arachnoidal hemorrhage, or the stroke, hemorrhagic stroke. So these are the things that are important to know. I don't want you to copy them right now. After we're done with the webinar, I'm going to send it to you. So you can see here that we're going to compare the left column over here and the right one, which is the tuberculous meningitis. So you can see that the onset is sudden compared to the gradual onset in tuberculous meningitis. Now, also, what is really interesting over here, so the meningococcal meningitis is always manifests with high fever. By high fever, I mean it is 3940. There's cephalgia, there's nausea, there's vomiting, Sorry, there's no nausea here. But here, in this case, it's even not present over here. The vomiting and nausea is not common for tuberculous meningitis. Now, why do I really specify these things, and why do I tell you to kind of focus on this? Because you never know what kind of patient could be admitted to the hospital. And last year we had a patient admitted with, well, didn't know. So basically he deteriorated right in the middle of a admission room, and so he had seizures, he couldn't breathe. We put him on the artificial ventilation, and we had to intubate him. And then we did the CSF, the lumbar puncture. What happened actually? Well, we'll talk about this when we did the laboratory diagnosis. But then what we did when we collected a sample of the CSF, after half an hour, we noticed a firm fibrinous film, which is very common for tuberculous meningitis. So without even waiting for the lab to give you results on whether it's bacterial, viral, or whether it's the serous meningitis, when you see that film, oh, okay, that's tuberculous meningitis. And it's going to appear on the CSF fluid within 30 minutes, an hour, the latest. So it is fast for you to understand this. The reason why you need to do that, because the treatment is going to be different. Because even if you apply the antibiotic treatment for the meningococcal meningitis, it's not going to work for the tuberculous meningitis, because you know that it's acid-fast bacteria, which has very firm capsule, very difficult to get through. So these symptoms, right? What you can see in the CSF once you do the count, the cytosis, you will see that it's moderate, significantly increased in the neutrophils, in the macrophages, and in the tuberculous meningitis, you will see that it's lymphocytic. It's mainly the lymphocytes going to be present in the tuberculous meningitis. So now the glucose content as well, you can see that in meningococcal meningitis, you can see that it's moderate or significantly increased. However, in tuberculosis, it's going to be significantly increased. Reason why? Because the consumption of the glucose by the bacteria is high. So of course, they're going to consume lots of glucose. All right, so I'll leave this table on you. Basically, you can go through that on your own. It's not like I really have to spend a lot of time on that. So when we go, okay, yeah. Now we have, this coming week, you're also going to be asked such questions as, what is the difference between meningism and meningitis? So meningism, that is the syndromatic complex of the symptoms which is manifested as meningitis. However, it's transistent. So, and meningitis is persistent. Meningitis remains for a longer time. Meningism comes and goes. Also be because of so especially in poorly developed families, in those families who don't really have well-defined moral status. You know, when they take care of a child, they take the kid and they start shaking the child. So when the head is shaking back and forth, the brain eventually will hit the occipital bone, and that is intracranial injury, which will lead also to development. Well, again, you will have the traumatic inflammation of the meninges, so it's going to swell in that area. Once it becomes swelling, it's going to press. It's going to increase the intracranial pressure, so the child will have the development of the meningitis. meningeal signs. Okay. And you can see that cytosis in meningism is very low, of course, because there's no immune reaction. However, you can see that in a purulent bacterial meningitis, you have a huge amount of neutrophils. Okay. Now you can also compare the protein count. Protein, where does it come? The protein comes from the dead cells. Okay, so the cells die, and then they will release the protein. So you can see that it's not that many cells that really die in the meningism compared to the purulent. It can go up to 16 grams per liter. All right, so basically the protein in the purulent bacterial meningitis, that's the one that will lead to the turbidity increase, viscosity increase, as well as it's going to change the color. So you can see that the turbidity reactions, the Pandy's reaction, you could, this is an MCI question, it's a high yield, so I would really encourage you to kind of note it down somewhere because it does appear in the MCQs. The Pandy's reaction, that is the turbidity test, which is you basically use the phenol to test the protein count in the turbidity and the protein count in the substance. And you can see that again in the meningism it's low, and then in the meningitis it's quite high. Now a lot of you will be asking the question, what is xanthochromis? So xantho means yellow. So xanthochromis is going to be as a color of the tea without milk. Okay, so it's brownish, yellowish, transparent, but it's still yellow in color. Yeah, I guess I tried to explain this table a little bit to you now. One of the procedures that is not only used for the diagnosis measures, it's also used for treatment measures, and it's called lumbar puncture. You of course know what it is and where it's done. We'll talk about it in a while. But then what happens, since you have the increased intracranial pressure, there's a lot of CSF inside. So what can you do? There are two things you can do. One is to do the CSF and drain CSF from the canal of the spinal cord of the spine, or else the other thing what you can do is to do the perforation of the temporal bone over here. Of course, this one is more traumatic, so you wouldn't really go for that. But it depends again on accessibility. If you don't have a needle, if you don't have a specialist, and you're in the middle of nowhere, this is something that you can do to relieve the intracranial pressure. Because if you don't, it may result in the myelocele, or else it's the spinal cord herniation into the foramen magnum, and medulla oblongata gets stuck in the foramen magnum. And what happens, the C1 and C2, as far as you remember, it contains the nuclei for respiration and heartbeat. So basically it will result in death. So the two ways you can do, that's the perforation of the temporal bone, or it's the lumbar puncture and the drainage of the CSF. See here that the puncture usually results in significant relief, and it often is the breaking point of the disease. So after you relieve the intracranial pressure, the patient will feel much better. Now, same thing in serous viral meningitis. Once you drain the CSF, once you relieve the intracranial pressure, the person will feel much better. Okay, so moving on, we have The classification, this is something that I really want you to know, because in the module, usually when you see the classification, then you start saying, "Sir, but I've never seen that." No, there is classification for each disease, and it's either by the localization of the form. It can be localized. In this case, for the Neisseria meningitis, it's bacterial carrier. Usually it's in the nasopharynx. The bacteria remains there without causing any disease. And well, we also use the term of asymptomatic carrier, because usually the person doesn't develop any symptoms, and eventually can lead to the contamination of a huge amount of people. And then you have nasopharyngitis. So basically the disease, well, it starts in the nasopharynx and finishes there without moving any further. Okay, so these are the two things that you need to know. Of course, these two things will depend on the immune status of the patient and the immune reactivity to the causative agent. Of course, it will depend on the infectious dose, either it is high or low. Now, the generalized forms will lead either to meningococcemia, and that's the meningococcal sepsis. The meningococcemia can have forms as well: typical, atypical. So it's with the rash, without the rash, with metastasis and without metastasis. Now, you're used to the term of metastasis, and that is the cancer or oncology in tumors, right? But in this case, it has nothing to do with oncology. Metastasis means that a certain piece of pus with the macrophages and with the bacteria will travel along the bloodstream and will end up in some other organs. And then you have the meningitis. The meningitis can also have a mixed form, which means meningitis and meningoencephalitis. So that means that there's going to be the inflammation of the meninges and the brain tissue itself. Okay. Okay. I request to all please switch off your videos. All right. Well, they don't bother me though. I can see Samir and someone else. They don't really distract me. The rest, you can take screenshots. Yes, you can take screenshots. But yeah, of course. Yeah, you can do that. But I'm going to give you the presentation, so there's no point of doing the screenshots. All right. So let's see. We're going to have. All right. Then you have the classification according to the severity of the course. And again, you have mild, moderate, severe, and very severe, or we call it a hypertoxic or fulminant form. Okay, that means that the development of this disease is going to be very fast. Now, you have the according to the duration of the course, which is acute, protracted, and chronic. Then you have major complications: infectious and toxic shock, swelling of the brain, which is we call usually cerebral edema. And then you have DICS syndrome. We'll talk about that. There's Waterhouse-Friderichsen syndrome and acute renal failure, respiratory distress syndrome, and then ependymatitis. Do you know what is ependymatitis? Yes or no? No. Okay, ependymatitis, that is the inflammation of the ventricles, intracranial ventricles, okay? Now, I want you, just in the notes, or maybe, because I only see the two pictures over here, so everyone else text me yes or no if you know all of these listed here. If not, write down which ones you don't know so that I can talk about them, okay? Just text me the name and then we'll discuss that. So the clinical forms, if you're asked in the module, write down the clinical forms of meningitis, you have to write localized, generalized form, and then list down the localized and the generalized forms. As well as Rohit Mahila, please don't say just no. Tell me what exactly you don't know. Just write down the name, which you don't. Waterhouse Fredrickson. Okay. All right. Just keep it there. When I'll move on to the pathogenesis, I'll discuss that. And then you have the rare forms. This is more as a complication, and that's what I say. Remember the ones that we just discussed with the metastasis. So these are the ones you have: endocarditis, arthritis, pneumonia, iridocyclitis, and the uveitis. Now the iridocyclitis, that's the inflammation of the iridus, which is the one the colored circle around the pupilla. So that is the iridocyclitis and uveitis. All right, the next one which we have over here is the description of the Neisseria. Now, this is something that all of you miss when we talk about etiology. So I really highly encourage you to pay attention to this part of the presentation over here, because that's basically your understanding of the whole disease. Now, it is encapsulated, which means it has a capsule. And the capsule of this gram-negative diplococci plays a very crucial role in the pathogenesis of the disease. Now you have, well, you have the second most common, that's whatever, screw it. Pathogenicity, it has pili. So the pili, they have double function. One is basically it helps for the attachment. The other one, it helps to find the receptors for the attachment. And basically it helps them to colonize the non-ciliated cells of nasopharynx. So remember, we were talking about mucosa, and we would usually talk about the ciliated epithelium. In this case, the cells that are really get affected in this case, it's non-ciliated cells. Okay. Now, it also has LPS, the lipopolysaccharide, which basically helps. It's the capsule of the bacteria that helps us to hide from the immune system, which protects from the specific immunity, from the antibodies. We'll talk about that in a while as well. So, and then of course you have the toxin and the endotoxin in this case. And remember, I always tell you in class that if there's endotoxin, you don't want to kill the bacteria. You need to reduce the toxicity first. The serogroups A, B, C, Y, W135, these are the ones that are present there, and basically they depend on the capsule. So the capsule, the serotype of the capsule makes the serotype of the bacteria. Okay, so as you remember, of course you do, from the microbiology, you have the cytoplasmic membrane. That's the most nearest to the cytoplasm, right? The inner part of the bacteria. And then you have the cytoplasmic membrane, that's right here. And then you have the periplasmic space. So it's the skin and basically the jacket that bacteria has, okay? So it's the space between these two. That means that it's not really tightly attached. It means that you can remove the capsule, okay? And the bacteria will still live. And then you have the outer membrane right here. This is the outer membrane. The outer membrane, so you can see the thick layer of lipo-oligosaccharides. Lipo means fat, lipids. Oligosaccharide means a huge chain, these huge chains of glucose, okay? Why is it so important? Why this lipopolysaccharide, why is it so important for us to know? Because this helps this bacteria in a lot of cases. Number one case, it helps the bacteria to evade the immune system. The second thing, it helps the bacteria to survive in the environment. Neisseria meningitis, after drying on the glass, on the smear, can survive for 8 days after drying out. So that means that in the normal environment, when, you know, this, a very common thing that some people do, and then they spit on the floor, it can live there for 3 weeks. Okay, so that's why it is important, because it means that in the epidemiological matters, it is important so we know how to manage the outbreaks. Okay, and then you have the capsule. All right, so this capsule, it's not just like it's outside, it goes deep in between of the lipopolysaccharide over here, down here. Okay, then you have the pili, or the fimbriae, you can call them anywhere. Now, outer membrane proteins, these are the ones we will talk about them. The protein 1, protein 2, and protein 3. And well, you've heard of POR A and B and OPA, OPC, the opacity proteins. And the phospholipids right here. This is the phospholipid right here, and right here. So these phospholipids basically they maintain the viscosity around the bacteria itself. So you can hear these things right here. Just write them down because that's something that you will need. The surface adhesive proteins. It's type 1, type 2, type B. So, and the porins, POR A and B, and the OPA, OPC. The OPA, OPC, basically they belong from the name opacity. So these are the adhesion proteins. For the module, I just want you to list them down, that's all. All right? Yeah, and of course you need to know that the bacteria contains the endotoxin, which is a long-chain lipopolysaccharide, or LPS. Well, okay, yeah. Now, one more thing about the capsule that I want you to remember. So it is not just essential for the survival of the organism. It will also it will provide the resistance to antibody complement mediated killing. And I want to see one thing. Can you, what happened to the sound? Nothing. I'm still right here. 2242. Can you still hear me? Okay. Can you guys hear me? Okay, good. Could you please also tell me, do you know what is the complement? The immune complement. Do you know? Just say yes or no. I just want to see. Yes. Horia knows. Very good. All right. The complement. Okay. So most of you know. Still, we'll stop on that. You guys don't know. Okay, good. I'll tell you what it is just in a bit. Okay, we'll move on to that. Viewer 38, are you ready to present? Stop it. It's a lot of presenters today. So basically, this is the schematical pathogenesis. So you have the diplococci over here, and this is the pilus. The pilus helps to find the receptor, and then you have the OPA and OPC proteins, the opacity protein, which helps to attach to CACAM receptor on the cell membrane. So if you just remember these names, it's easier for you to remember how does the bacteria get inside. Okay, now this is the POR B, which requires AMP for the action. Don't go deep into that like that. Just, I want you to know the list of the proteins, and you telling me that these proteins are required for adhesion and entering the cell. Bus. Okay, I don't want you to do the PhD on meningococcal meningitis. All right. So again, capsule, the polysaccharide, it surrounds the bacteria. It helps the bacteria to survive in the environment. There are 9 serotypes currently discovered: A, B, C, D, X, Y, Z, and blah, 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 blah. Do you need to know them? Yes, you do, because depending on that, we have the vaccine. So it would be helpful if you would remember at least, you know, it's not that difficult. The most common is A, B, and C. Most common meningitis in sub-Saharan Africa is type B. then the endotoxin, which is the lipopolysaccharide. And so remember, I told you to tell me about the complement. I also want you to remind me about Waterhouse and Fridriksson and the petechial rash pathogenesis. Okay, so we'll move down and then you'll remind me about that. So we have also the IgA protease. So the immunoglobulin A, that is the immunoglobulin which is always present on the mucous membranes. It's basically the innate immunity. You're born with it, okay? This is something that your parents and your ancestors were ill with, and they passed this immunity to you. The funny thing is that, so the Neisseria meningitis developed the cleaving factors, and this enzyme is called IgA protease. So basically, it's not scared of any type of the immunoglobulin A's. It's quite easily entering the cell, and then it promotes its own action, whatever it wants to do. Okay, the rest is just for you to read a bit. It can use the transferrin and get the iron just the same the same way as the Mycobacteria tuberculosis. It has the same activity. All right, so just again to remind you, it causes meningitis, septicemia or bacterial sepsis, and then you have meningoencephalitis, pneumonia, arthritis, urethritis. Okay, common diseases caused by Neisseria meningitis. So here's how it looks, the smear under the microscope when you do the microscopy of CSF. So you can see the red one, of course, is the blood, and you can see these. Well, I understand that for you it looks mainly like a chicken curry, but so these things over here, right here, these are the macrophages, okay? And these macrophages, these dots, these little dots over here, those are the bacteria inside the macrophages, which you can see. So this is what we can call pleocytosis. That's what they do. They do the microscopy of the CSF, and in the microscopy of the CSF, they can see a macrophage, and inside the macrophage, they can see the bacteria. So you will get both. They will tell you cytosis. Cytosis means the amount of cells. And also, they will tell you the amount of bacteria inside those cells. For instance, we had a person that came seropositive for meningococcal meningitis. That means that they did the serological test, serotyping, hemagglutination. Hemagglutination came out positive, okay? Then what they did the CSF, the lumbar puncture. They did the microscopy of that. And in the microscopy of the CSF, they only found leukocytes. There was no Neisseria. What does that mean? That means that the person may have had some chronic latent form of meningitis. The immune system killed the bacteria, okay? The person survived the disease. There was the immunity developed to that. That's why the IgGs came out positive. But the cells were negative for the bacteria. Right here, this is the macrophage over here. Segmented cells. Remember, in the DLC, you have band cells and segmented. For instance, this is the band cell. You see the nucleus is still huge. These are the segmented cells. You can see 3 nuclei here, and this is the bacteria inside the macrophage. Okay, so this is what we do. It's the algorithm for the diagnosis of the Neisseria meningitis. Now, this is something that I want you to write down. Okay, number one thing which you do when the patient is admitted to the hospital already, few things that you do. Of course, you're going to do the CBC with DLC. You want to see whether there is leukocytosis. And mainly, commonly in the DLC, you will see at least 15,000. That's the least you can see of the leukocytes, the neutrophils. Eventually, what's going to happen, you also need to do certain tests. Number one, you take blood for blood culture and sensitivity test. So you send the blood to the microbiology lab so that they do the culture. Number two, you do thick blood smear. Thick blood smear. So they can see the Neisseria, they can see this Neisseria inside the leukocytes in the blood. These two things, number one and number two, you do for the reason because you suspect meningococcemia or meningeal sepsis or meningococcal sepsis, okay? Now, to diagnose meningitis, of course, clinically, you will see the meningeal signs positive, Kernig's, Brzezinski, stiff neck, but you also have to do the lumbar puncture. In the lumbar puncture, you will draw the CSF, and again, you will take 3 samples of the CSF. Number one, you send to the microbiology lab for the culture and sensitivity. Number two, you're going to use for the microscopy. Immediately, you do the microscopy because you want to see the pleocytosis, because you want to see the cytosis, because you want to see the bacteria inside the CSF. The third one, you also send to the lab, but they will do the biochemical analysis to find the protein count, the glucose count, all those things. Okay, so you take the blood sample and you take the CSF sample. Both of them are going to be sent to the bacteriological lab and to the hematology as well. You need to do the CBC and DLC, and you do the biochemical analysis of the CSF as well. What you need to do, because if you do the biochemical analysis of the CSF, you will figure out the glucose count. You will figure out the protein count, which will help you to diagnose either it is bacterial or viral, or maybe it is the subarachnoid hemorrhage. Okay, because in mainly in meningococcal meningitis, you should not be seeing erythrocytes, especially fresh erythrocytes in the CBC. However, in subarachnoid hemorrhage, there's going to be, the CSF itself will be red. And if you go back to those few slides that I have at the beginning of this presentation, you will see in the table there's going to be differential diagnosis between the hemorrhagic subarachnoid hemorrhage as well. All right, so what do we need to know in terms of epidemiology? Number one, it's anthroponosis. Animals are not getting sick with this disease, okay? It's person to person, transmitted through aerosols, which means air droplet or airborne mechanism of transmission, okay? Usually it's close contact. It's basically family members, schools, institutions, work, whatever you want. But you should not forget about one thing: bus. And bus, not from Hindi, which means Finnish. Bus means the car, because very often you think, this is not for me. I'm not going to get sick with meningitis. But the recent case we had, a lady actually died. She died of sepsis. She had meningococcal meningitis. 86-year-old woman. Does she go to school? No, she doesn't. Epidemiologically, you wouldn't think that. Well, you would be guessing where did she get the disease, but she could get it on the bus. She was going, grocery shopping or something, or getting her pension. You don't know. So that's why you should always consider that even by the public transportation, that's how it can be transmitted. The highest incidence, of course, is the kids below 5. Why? Because the immune system is not really developed fully yet. But what you need to also consider is that that's why we actually provide the vaccination for the children below 5. Yeah, so then usually or commonly it colonizes the nasopharynx, and then it moves from there. Let me tell you, there was a story of a family, a father. Yeah. So we get a mother with meningococcemia. It means that she was getting this very weird potassial rash on her ankle. So when she came, and she had high fever. When she came, we did the blood smear, and we found the Neisseria over there. However, you should also be very cautious about doing the smears of CSF and blood. Write this down somewhere, the MB, nota bene, because when you do it the first day, you should repeat it after. You should always confirm it with the culture the next day or the day after. Why? Because the first day you may see diplococci, right? But then after a few days, you will see that it's diplobacilli. Because what happens? Can you see? I hope you can see. So so diplococci, they look like this. Can you see over here? Right? No? Okay, good. So after a few days, you will see diplobacilli like this, because they will grow. So listeria is diplobacilli, Neisseria is diplococci. So you may think you're dealing with Neisseria, but you may be actually dealing with listeria. Write this down and ask me this question in class. I'll tell you these two stories, because we had a listeriosis positive meningitis 2 years back, and also we had, I'll tell you the story about this family. So, so the woman was admitted first, and then her daughter became ill with meningitis. It was not just meningococcemia, it was meningitis a few days after. And then their youngest brother, actually, it was a family of 6 children. So all of them were admitted with, so 3 of them